Hello, everyone. Welcome to this webinar hosted by the NCCHPP about implementing health in all policies approaches in Canada. So we're really happy to have you with us. Before we get started in about the content of the webinar, a few housekeeping issues. Or a few technical information. So we have two ways of communicating with each other today. So the first one is through the Q&A box that you see below on your screen. So we ask you to use the Q&A for two elements. If you have any questions for the presenters, at any time in the webinar, you can write down your questions in the Q&A box. And at the end of the webinar, our colleague Natalia Botero will be happy to share some of your questions with us, and we'll try to answer them the best we can. So at the end of the webinar. If you have technical questions, any technical issues, or want more information, you can also use the Q&A box, and our colleague Mylène Maguire will be happy to try to help you or answer your questions. If you have more general comments or want to share resources with everyone, please use the chat box also below of your screen. So for questions for us, please use the Q&A. For comments for everyone, the chat box. The webinar, the webinar will be recorded, including the chat and Q&A boxes. And this recording will be available on our website after the webinar. You will also receive an evaluation form through email after the webinar. So we ask you to take a few minutes to please give us some feedback so we can improve our webinar as we move forward. So today we have three presenters. Myself, my name is Martin Renaud. I'm an expert scientific advisor at the NCCHPP. Also my colleague, Nicole Bernier, also an expert scientific advisor at the NCCHPP. We've both worked on projects related to health in all policies, so we're happy to be here to share some of the things we've learned with you. And we're also very pleased to have with us Patsy Betty Huggin. She's the coordinator of the Atlantic Summer Institute on Healthy and Safe Communities. She has a background, a vast experience in nursing education and health system redesign. So we're really lucky to have her with us so she can talk about the experience of Atlantic Summer Institute with HiAP. So for those who don't know us very well, we're the National Collaborating Center for Healthy Public Policies, or NCCHPP. And our role is to support public health actors in their efforts to develop and promote healthy public policies. So we work on a variety of projects. You have the list there. And so for all of these projects, we try to create resources and informations like this webinar for public health actors so they can improve healthy public policies and put them in place. Our center is part of a wider network of 6 centers situated in different regions of Canada. Each center works on different aspects of public health, and they all have very interesting resources to share with you, so you can consult them on their websites. So before we move forward, I'd like to make a land acknowledgement. So we acknowledge that we are on an age-old Indigenous territory, a place of meeting and diplomacy between peoples, and the site of the signing of the Great Peace Treaty. So we thank the Kanien'kehá:ka Nation for their hospitalities on this unceded territory. You're welcome to share your land acknowledgement in the chat box if you wish. So the outline for today's webinar, so we have different sections or parts of the webinar. So I will start by doing a brief introduction on the concept of HiAP. I'll be very brief on this. After, Patsy will talk about the HiAP experience in Atlantic Canada through the eyes of the Atlantic Summer Institute on Healthy and Safe Communities, and she'll take a close look at the project, specifically in Prince Edward Island. After this, Nicole will talk about mobilization approaches to health in all policies. And lastly, I will be talking about trainings for HiAP, the different challenges and reflections that one of our reports talked about. And at the end, we'll have Q&A period, as I said before. So if you have any questions for the Q&A, please use the Q&A box. So just a few words on the approach itself. So there are several definitions for HiAP, but we'll use the WHO definition. So they define HiAP as an approach to public policies across sectors that systematically takes into account the health implications of decisions, seeks synergies, and avoids harmful health impacts in order to improve population health and health equity. So as you'll hear sometimes in the webinar, we sometimes use plural approaches because there are different ways of conceiving health and all policies, but it's all about intersectoral work, bringing people together from different sectors to improve health and especially health equity. So in other words, it's all about different sectors outside of health that can contribute, work together, put in place policies that improve the health of a population and decrease health inequalities. So in this context, the WHO, the World Health Organizations, have put forward many different resources to help countries put this in place, such as the Framework for Country Action that came up in 2013. And in continuity with this, many different jurisdictions around the world have adopted HiAP. So for example, South Australia, Finland, California, and many others. As we'll see in Nicole's presentation, some jurisdictions in Canada have done so as well. And also in Atlantic Canada, so that Patsy will be able to tell us about this. So I'll give the floor to Patsy. We're eager to hear what you have to say. Good to you, Patsy.
I'm really happy to be here, and on behalf of the Atlantic Summer Institute, privileged to be invited to collaborate with the National Collaborating Center and also share our experience and emerging insights on moving forward with mental health in all policies, which is really quite intriguing and exciting for us. So first, before I begin, I would just like to say I am in Prince Edward Island right now, but I'm acknowledging that ASI is based out of Mi'kma'ki, the ancestral unceded territory of the Mi'kmaq people. And this territory is covered by treaties of peace and friendship with the Mi'kmaq and Willistic people, first signed with British Crown in 1725. We not only recognize and respect that the land we're settled on is Mi'kmaq, but we also actively advocate for the implementation of Truth and Reconciliation Commission calls to action and strive to include Indigenous perspectives in all our work and have been for many years. So the Atlantic Summer Institute itself, I'd like to introduce you to because I'm sure many of you are not familiar with this organization. It's actually a nonprofit organization that was established in 2003. Based in PEI, and it's been in its mission a catalyst for social change in Atlantic Canada, focusing on developing leadership for the determinants, take action on the determinants of health. It's managed by a regional board of directors with membership from each of the Atlantic provinces and from very diverse populations in Atlantic Canada and age groups. So we span from youth to those over 65. And from many different ethnic backgrounds. And traditionally, we have held an annual forum that convenes civil society on various regional issues based on our demographics and issues moving forward, all built on the Circle of Health, which has been adopted as our planning framework and curriculum framework for the Atlantic Summer Institute. Since 2015, we focused on child and youth mental health promotion because we were invited to do so in 2014 by the Canadian Mental Health Association in Nova Scotia, who was looking for a knowledge translation partner to actually share some of the work they were doing on social and emotional learning and mental health promotion. And since then, we've learned a lot and really discovered that if we're going to move forward with child and youth mental health promotion, it really needs to be a whole of government approach with intersectoral action, a whole society with many different stakeholders, including private sector representation, and a whole of community, supporting community resilience. So we've moved forward a lot with that. In 2015, we held our first summer program focused on child and youth mental health. And then we're asked if we would continue with that focus for the next 3 years, which we did. So by 2017, 2018, there was actually a call for action that had been developed on really wanting some shifts in policies, programs, resources, and funding. And in 2021, during the pandemic, when we had shifted to a virtual program of delivery, and I was really questioning how connected we could be when we weren't all in person, the mobilization was so much so that we had actually had about 20 different people put up their hands when the question was asked, would anyone here like to be involved in developing a policy brief on upstream investment and child and youth mental health? And when I say a number of people put up their hands, these were people who represented a variety of organizations, both regionally and nationally, who all were seeing that the kind of direction we were taking and the momentum that we had under our belts right at that time were worth investing in. And over a year, these groups came together with a lead from Away Home Canada, and actually had many different working groups. About 5 different working groups were going on, developing the brief, looking at evidence, really establishing the elements that needed to be included in the brief. And so you can see that there were at least 35 people that were involved in this over time. And it was actually built on a premise that said that raising healthy children is the responsibility of all Canadians, that promoting and supporting infant, child, and youth mental health is central to enabling them to become lifelong positive contributors to their communities and society, and that strengthening policies and programs that support positive mental health for children and youth is vital to creating an inclusive and equitable Atlantic Canada. And I think the belief is that if this can happen in Atlantic Canada, it can happen across the country. So our focus is upstream, as is the efforts and the realizations that we had become to believe in. And this on mental health promotion, which aims to enable people and communities to optimize their well-being by influencing multiple determinants of health, and really wanting to equitably improve mental health of the entire population and reduce likelihood of mental deterioration. And we had actually developed a resource in 2017 that was called Mental Health is More Than You Can Imagine, that includes a lot of the definitions, a lot of the actions that we might take to create a mentally healthy society, and the fact that we can all be part of that. So the goal itself was really quite clear. We wanted to enhance intersectoral action amongst the various sectors to advance upstream investment in policies that promote equity and mental health amongst infants, children, and youth in Atlantic Canada and beyond. And you probably realize that we're now including infants. And this has come as more research has evolved on brain development and ACEs, and so much of what we know about the prenatal state and the importance for infants as well. So having done that and been more inclusive in terms of the evidence that we gleaned to put together to support this brief, we identified 4 anticipated outcomes, and that would be wider engagement of the public and leaders in support of upstream investment and resource allocation, increased collaboration between stakeholders, and new policies throughout communities and governments, not just in the provincial government or the federal government, but looking at our municipalities and our communities and creating a sustainable funding model for upstream policies. And our work is moving very much in that direction. We're calling for transformative change. We are asking for commitment to that change and challenging leaders at all different levels to undertake a fundamental change in the way we build healthy public policy. So we look at and credit Raising the Villages for these illustrations, but looking at our current system in terms of the scattered nature of it and how difficult it is to access and coordinate resources. And then think about some upstream coherence where there is some policy that is developed, and resources allocated to working across sectors to the benefit of communities, and communities interchanging with that body so that their policy comes from community and is also delivered in community. In doing all of that, there was a lot of work to try to distill what we were trying to say and how this could be implemented, and came up with 4 major priority areas. One is a whole of government approach by implementing a mental health in all policies framework, building on health in all policies framework. That meant that we weren't trying to create another framework. We have one solid one to build on, but this time really focusing on the mental health component. Taking a whole of society approach through development of a multi-stakeholder platform. And this could be at the provincial level, it could be at the municipal level, or the national level, but really thinking about how do we have a platform where we can bring in civil society, private sector, academia, and governments. A whole of community approach, really recognizing that communities are doing a lot of the work now and needing that investment to be seen as partners in the work that they're doing. And so that call for investment in community has been one of our priorities. And then lastly, a sustainable and integrated funding model that supports these approaches and really stops in the tracks of one-year project funding, but rather looks at some of the work that can be done over time beyond political cycles, and keep organizations going that currently it really relates and interacts with the investment and community approach, because so many community organizations right now are really funded through projects and struggle with mission drift, need to have that sustained work in order to make the big difference. So having said all that, and those are our actions, we're now moving forward and are very lucky to have funding support for knowledge mobilization for the past year, and supported in this one-year grant by the Public Health Agency of Canada Intersectoral Action Fund, which was awarded in 2022. We've had lots of activities that I'll be reporting to you on from that involvement in that fund and in that project. And the policy brief is available in many different formats, as you can see. So that's one of our big pieces of work this year, and we've been all moving forward with a lot of effort in trying to make that happen. So the project itself that's funded by the Public Health Agency of Canada is called Mobilizing Intersectoral Policy for Upstream Investment in Infant, Child, and Youth Mental Health in Atlantic Canada, with this goal in this project to enhance capacity for intersectoral action amongst governments, private sector, and civil society to advance the upstream investment in policies that promote equity and mental health amongst infants, children, youth in Atlantic Canada and beyond. And one of the reasons that we received the funding is the project is to further the efforts of the Public Health Agency of Canada to foster effective intersectoral action for health equity and well-being. So we're working hand in hand with that. Sorry about that. Much of the activity, the knowledge mobilization activities that have happened since March with the policy brief launch have been a live stream announcement of the funding itself, which happened in May, a presentation to the International Union of Health, Education and Promotion in May, Intersectoral Provincial National Steering Committee, which was established in June with representatives from many of the organizations that supported the development of the policy brief and many local organizations, an Indigenous working group, First Nations and Inuit representation that was initiated in June as well. We've had online Atlantic provincial workshops with provincial partners and hosts, such as the Canadian Mental Health Association in Newfoundland and Labrador, United Way on Prince Edward Island, Raising the Villages in Nova Scotia, and all of a sudden my mind has gone blank. Oh, the Multicultural Council in New Brunswick. Presentations have been requested and are ongoing. We have made several presentations in Nova Scotia. We also have been, and I will show you much of the activity on PEI. We held a policy forum in August of 2022 here on PEI. And we've also entered into a partnership with the National Collaborating Center on Determinants of Health, with having access to one of their knowledge mobilization specialists. We have been in communication with the Council of Atlantic Premiers, and we are now involved in this webinar. So we're getting out there and getting the message out, but we also have in the works 5 community workshops with community partners in each Atlantic province, community engagement workshops that have happened already with the New Brunswick First Nations Education Initiative, online First Nations workshop with Atlantic Policy of First Nations Chiefs, which will happen in February, and an online workshop in Labrador in March 2023. So that is the breadth of our reach in Atlantic Canada and the work that we are undertaking to move forward the 4 priority areas, mental health in all policies being one of them. But we also are very fortunate in that in Prince Edward Island, there was a new funding body established called the PEI Alliance for Mental Wellbeing that began a grant giving program that dovetailed with work that we were doing with the Atlantic work. So there's a project that we applied for and received funding for to implement mental health in all policies in Prince Edward Island, and to really provide the training and capacity to realize and sustain implementation of this over time. And it is 3-year funding. So it will be able to move forward with beyond the facilitating the conversation and the knowledge mobilization piece to really take it forward into some training, developing materials, working with HR departments, and then into an implementation evaluation. So lots of happening in that front as well. And we have since March been able to, of course, get the media coverage for the launch, but also start meeting with our political caucuses. Had a presentation with the PEI Legislative Assembly, and actually what happened there, I will show you. We really had some great success with a motion going forward to the Legislative Assembly. And with that motion, with unanimous approval to go ahead and support the work that was recommended in the policy brief. We received some funding from a PEI Alliance on Mental Wellbeing. We've spoken with our Minister of Health and Wellness. We've presented to the Standing Committee on Health and Wellness. The Public Health Agency of Canada funding announcement came on May 26th, and it also had a lot of live streaming that went with that, and that went out through Atlantic Canada. We've met with Deputy Ministers of Social Policy, and we've just presented for the PEI Alliance on Mental Wellbeing Board and education sessions. Having said all that, we followed up with that. So we've had a provincial workshop in PEI that is part of the Atlantic project with the funding from, or the hosting by United Way of PEI. The forum took place in Charlottetown at the Holland College. Our advisory committee locally for this project, the PEI project, has been meeting since October and has moved forward with an understanding of we're meeting by Zoom. We only meet once a month, but we really haven't met each other, and we need to learn from each other about what we're doing that's upstream, and also what are the concepts that are in this policy brief that we need to understand more so. And I'm going to explain that to you in a little bit as I go along. So we've had further consultations. We've moved in that has really been synergistic in terms of a partnership with the PEI Coalition for Women in Government, which has some funding. And we're working with the Community Sector Network in holding a workshop, a community workshop here on PEI. We also are engaged in capacity building research for training programs, tools, and resources. So for that period of time, we've been very busy. And I think one of the most encouraging things that we have is the motion that went forward to government to undertake this fundamental change in which it builds healthy public policy and to implement recommendations of the brief. So this has been a lot of investment in knowledge mobilization, but as a result, we do have this unanimous approval of a budget in March 2022. And where it brings us to, as a PEI advisory committee, is, do we have a collective understanding of the concepts in the policy brief? Do we know our collective interest in upstream? Do we understand the concepts that are in the brief itself? So wanting to know more about the brief and also about health and all policies in Canada generally, we held this Connect and Learn and invited Nicole and Martin to present on their work. It was exceptionally important and met the objectives for that advisory committee. And they began to think ahead in some discussions of what could mental health and all policies look like for PEI? What steps can we take? And I must say that this advisory committee is actually very broad in terms of its representation and represents many different sectors and organizations in PEI. And as I looked at it closely, I was thinking this actually is developing a multi-sectoral platform in a very informal way, but that's really what it has grown to be. So how will the PEI government be engaged? They've determined it's probably going to be stories and allies. And then how can we build on current lens for policy? Because there's lots happening on PEI right now in terms of policy reduction, lens of diversity, sustainability, anti-racism, gender sensitivity, reconciliation. There are lots of different lenses that are being placed on policy now. But how close is PEI to implementing health and all policies, which of course would really assist with our investment in and wanting for and advocating for mental health in all policies. So at our next meeting of the advisory committee, we invited Laurelie Noonan, who is manager of the Health Promotion Division of our Department of Health and Wellness, to review the interest in health and all policies and bring us a historical context for PEI. And she reported lots of discussion and recommendations. And this was of interest for us because there were several reports since 2016 that had been recommending a health and all policies approach. And there had been a motion put forward much earlier by the official opposition encouraging health and all policies, but it hadn't been voted on. It was at the very tail end of the meeting of the Legislative Assembly at that time. So it's not that it was all brand new, but we wanted to know more then about where does it fit with what's happening at the deputy minister level, and invited Deborah Bradley, who was deputy minister of the PEI Department of Health and Wellness, to help us understand more fully what do the deputy ministers have in social policy, have in advising government, and what's the collective understanding and motivation for health and all policies across departments, and how close are they to taking action on that motion 83, because we have a motion, but without action, it doesn't become reality. So what we really learned from that is there's appreciation of upstream investment. There's lots of collaboration amongst the deputy ministers. It's advisory in nature with many lenses at play, but there's no overarching structure or formal process for that whole government approach as yet. So we're invited now the Deputy Minister of Social Development and Housing to present at our next meeting. During this course of action, we discovered that the PEI Coalition for Women in Government had been successfully awarded a project, funding for a project called Fostering Resilience in Women Municipal Leaders. And that this was going to involve meeting with newly elected and currently elected women who are involved in municipal government in municipalities over the next year. And this would be, they were partnering with the Federation of Municipalities, which were really a group that we wanted to reach out to. And this provided that lead in to actually be able to work with elected municipal officials. We also learned that there was a lot of work that's already been done and on the website for the National Collaborating Center on health and all policies at the municipal level. And I think a condition that here that made it very much possible is this funding by the PEI Alliance for Mental Well-Being, which is a contributing factor that would not have allowed for these organizations to be funded to take on these projects, but now is encouraging these partnerships. As a result of that, we're looking at the possibility of this partnership with the coalition as being a pilot for developing capacity in mental health in all policies, and have applied for some funding from SHRC in order to do that. So there's one thing has led to the other, and it seems like it's not just knowledge mobilization. We're really moving more toward action rather than just conversations. And in conclusion, we will be having ongoing conversations with our PEI advisory committee and stakeholders. We will continue to do research. We will be building case studies of municipal experience and documenting it. We will all be participating in the community sector network meeting and workshop that's going to be held on March the 14th. And we will be and have been invited to have conversations with intergovernmental affairs in the 4 Atlantic provinces. As what we did learn is that it is not common for an external organization to be speaking and presenting to the Council of Atlantic Premiers, but rather to work with the intergovernmental affairs who are very aware now of what work we're trying to do. So having said all that, our own thinking is emerging. We're in the process of setting up advisory committees and looking local and having the conversations. It becomes more clear that there are people from all sectors who are interested in mental health in all policies. We are building from the grassroots up and building our understanding. And in fact, we actually are co-learning. So this co-learning modeling that we're doing models the collaborative processes that are required for health in all policies. And it's also facilitating our knowledge development and relationship building. We're hypothesizing that this may be the training model of the future for our group and for building processes and engagement and wider support outside of the political arena for that shift in policy direction that we really need. So we're on the move. We welcome your input, and I want to say thank you very much from all of us at the Atlantic Summer Institute on Healthy and Safe Communities. Thank you.
Thank you, Patsy. Hello, my name is Nicole Bernier. I'm a political scientist by training, a public policy researcher, and I work at the NCC-HPP as an expert scientific advisor. Some of you are probably wondering how one can mobilize public health actors, find partners and resources to promote health in all policies in a given region. And Patsy has provided an inspiring example. She has shown that a civil society organization can play a critical role in a region to mobilize communities, public health actors, political leaders, and resources towards having a HiAP framework and strategy in one's given jurisdiction, or even in more than one jurisdiction. So it's a bottom-up approach. This presentation will show that there is more than one possibility, more than one possible way to mobilize actors. I will provide a short story of how mobilization towards HiAP, a HiAP provincial framework and strategy has been done elsewhere, especially in the province of Quebec, where a HiAP strategy is in place. In the next few minutes, I will describe to you the characteristics of a HiAP policy framework beyond the official or formal definitions. Then I will present other approaches to HiAP in Canada and discuss in more detail how mobilization for HiAP occurred in the province of Quebec. Many discussions about HiAP question the nature of the concept itself. One recurring criticism is that it is imprecise and that its implications are vague when it comes to implementing it. Based on a survey of peer-reviewed articles analyzing how HiAP is implemented in different regions, I propose that HiAP involves 4 main characteristics. First, it seeks to positively impact the social determinants of health and health equity. Second, it seeks to inform and influence policymaking across sectors. Third, it involves collaborations between health and non-health sectors to develop healthy public policy. And fourth, HiAP is not a health sector strategy, but a strategy endorsed by the whole government. This slide shows different initiatives to adopt or to develop a HiAP strategy that come from within the formal health sector or from the government in different parts of the country. In BC, for instance, the Chief Public Health Officer's first recommendation in our 2019 annual report was to establish a legislated health and health policies approach in the province, utilizing a health impact assessment model. Interesting HiAP initiatives are also being developed elsewhere in the province. For instance, Vancouver Coastal Health now has a well-staffed and dynamic healthy public policy unit. Ontario is also engaging in a renewal of a 2012 initiative at the government level. I will go now for the province of Newfoundland and Labrador has been emphasizing the central importance of the social health determinants beginning in 2017, both as part of its global government strategy and as part of its healthcare strategy. It has adopted a comprehensive government strategy. As it relates specifically to HiAP, the government commitment states that this health and all policies approach will enable the government to make all decisions in a manner that strengthens focus on measurable improvements in health status. In 2018, the province enshrined HiAP in its public health legislation. All the policies adopted by the government must undergo an assessment of their potential impacts on the health of the population. Next, the province launched consultations on health reform that were based not simply on how to fix the healthcare system, but on how population health outcomes can be achieved. The province's 10-year health accord released last year states that there's a need to ensure a basic income, food security, and housing security in the province. So really the social determinants of health need to be addressed. So this province is one example of a top-down mobilization approach to HiAP. That is, HiAP's promoted by the government as part of its global governance strategy and strategy for healthcare reform. Official policy statements and instruments are there. So is the challenge now to mobilize wider support at all administrative levels in the healthcare system and beyond, in accordance with the governmental vision and priorities. Now I will very briefly describe Quebec's government health prevention policy for 2016-2025, only to set the table before I discuss how mobilization for HiAP policy, for a HiAP policy framework was done in the province. Quebec's HiAP's policy framework aims to improve the health status and quality of life of the population and to reduce social health inequalities. It's supported by 27 departments and agencies. I believe the count is up to 30 now. And they partner to lead 100 actions, and they work with 80 NGOs across the province. It has a budget of $40 million per year. While this is a policy for health prevention, it's not under the purview of the health sector, but that of the government, and multiple sectoral partners responsible for specific actions. Quebec's policy has all the four characteristics of a HiAP policy framework mentioned previously. If you want to know, if you want a more thorough description of Quebec's policy, you can view a recent webinar. Natalia will share the link with all of us. I will now show that the mobilization that led to the development of a HiAP policy framework in Quebec took place in two stages over several years. First, within the health sector, then with other sectors within the government and community partners. So within the mobilization within the health sector. On this slide, I have indicated a few milestones for the mobilization that took place within the formal health sector and that have been conducive to the adoption of a HiAP framework in Quebec. Many people who work today in Quebec's public health system don't realize that it took many years to integrate the functions and responsibilities for public health within the healthcare system and to develop the administrative structures that are in place today. Health prevention and promotion were progressively integrated with primary care at all administrative levels starting in the 1970s. CLSCs and newly created community health departments within regional hospitals were made responsible for specific public health programs, for instance, screening, vaccination, perinatal care. Universities began to train doctors, nurses, and nutritionists and other public health professionals in the mid-70s in their newly created graduate programs in community health. So there has been a professionalization of public health starting in the mid-70s with alternative approaches and values as compared to the biomedical model already established. Over time, the professionals trained in graduate community health programs integrated the administrative structures that were being developed, and they have contributed to changing perceptions and professional approaches in the healthcare system at all levels. The Rochon Commission at the end of the 1980s established a roadmap for Quebec's healthcare system transformation. And as part of it, it proposed a detailed vision of what was needed for public health and for health promotion and prevention in terms of administrative structures, programs, and legislation. The vision for public health was to influence the infrastructure that is in place today, nowadays. In the mid-1990s, many new public health structures were created that further asserted the public health vision and producing health beyond the healthcare system. So we saw the creation of 18 regional public health directorates, which were relatively independent. A public health branch at the provincial level within the Department of Health and Social Services. This new branch's mission wasn't well understood at first by those in place with affinities for the biomedical model, and the integration was not easy. Newly appointed public health officials at this level and managers had an opportunity to develop awareness around them at this administrative level as well. Yet over time, the new branch meant that public health interests were involved at this level, and importantly, they had access to the higher levels of decision-making in the Quebec government. The INSPQ, or Quebec's National Institute for Public Health, was created in 1998. Quebec's Public Health Act of 2001 reflected at the legislative level this time a modernized version of the role of public health and its evolving mandate over a period of 30 years or so, including with regard to health prevention and promotion and healthy public policies. I will get back to section 54 of this legislation in a moment, but before that, I need to also mention another milestone, that is the National Public Health Program for 2003-2012, which reflected the intention of the modernized public health law. It recognized the 4 core functions of public health: surveillance, prevention, promotion, and protection, but also 3 supporting functions: oversight of regulations, legislations, legislation and public policies affecting health. So this was a short story of how public health professionals have been mobilized so far within the healthcare sector and how their engagement at all administrative levels helped to advance a vision for healthy public policy development within these structures. Now, second stage, mobilization of other sectors. Of course, the stages overlap, mobilization of other sectors and the government. Some of you are perhaps familiar with Section 54 of Quebec's Public Health Act of 2001. It stipulates that the Department of Health and Social Services advises the government on all public health matters and must be consulted during the development of measures and laws and regulations that could have a significant impact on the health of the population. All ministries and agencies are required by this section to consult with the Minister of Health and Social Services when developing legislation or regulations that may affect health and well-being. It is then the responsibility of the department to advise the government. So here I have written some of the contributions of Section 54 to the advancement of healthy public policies and leading to the adoption of HiAP in the province. So some of the contributions are that it gave, Section 54 gave legitimacy of the health sector beyond the healthcare system. So you have a piece of legislation that formally recognizes the role of the health sector to advise the government, to advise other sectors relative to the social determinants of health and all the policy initiatives that might affect the population health. It also fostered awareness of healthy public policy in other sectors and in the government. So it fostered awareness. It also sustained the appropriation of a health reflex by other sectors. So now sectors are better aware of the implications of their action on the population health or the social determinants of health. And they have to develop a health reflex to think about what those impacts might be. It supported also a logic of action made of intersectoral or interdepartmental initiatives. In a nutshell, and to conclude here, how can one mobilize public health actors, find partners and resources to promote health and all policies in a given region? Patsy has provided one example where the impulse is given by a civil society organization. In my presentation, we have seen that the impulse can come from more than one source, or even concurrent sources, and that mobilization of resources, expertise, and data can be done differently. Mobilization in Quebec was first internal to the health sector, and then extended to other sectors and to the government. The developments that took place over several decades, as they were briefly described, were conducive to the Quebec HiAP strategy and framework with multi-sectoral actors and community partners that we have in place nowadays. In both cases, mobilization occurs not overnight, but over a period of time. So thank you very much. And I will now invite Martin to do his presentation.
Thank you very much, Nicole, and Patsy as well. That was very interesting. For this part, the last 10 minutes or so, the next 10 minutes or so, I'll present or summarize a report that just came out on our website a few weeks ago called Health and All Policies Training, Inventory, Analysis, and Avenues for Reflections. You can find the full report on our website. The link is there, but I think Natalia will share that link in the chat box. So I'll just summarize the main points of it, of course. So the objective of this project was to list and analyze existing HiAP training. So to see what exists out there, all the trainings we could find. And once we did this, try to identify tendencies in terms of format and content. So try to see how those trainings are structured, but also what do they focus on? What kind of ideas they present? What are the principles, the tools that they insist on? So we did this to first maximize existing resources and avoid duplication. So not redo work that has already been done, but also, and probably more importantly, it's part of a wider reflection about HiAP implementation in Canada. So we want to reflect on trainings and what can be done moving forward. So I'll just say a few words about the methodology that we used. We ended up finding 85 trainings, but it's important to say that we took a very wide definition of training. So in the sense that we didn't limit ourselves to just courses, for example, but we took any resource that could be used by professionals to learn about HiAP. So we look at workshops, guides, webinars, conferences, and university courses as well. So we ended up with 85 of them, and we did content analysis of these trainings. So we did both a quantitative and qualitative analysis. Today, I will just talk about the qualitative findings, even if we did, of course, look at quantitative as well. So a few of our results or findings, in general, in the trainings that we've analyzed, HiAP is presented both as political and technical, in the sense that it's presented by the trainings as an approach that professionals can integrate into their work. So something that they can learn about and put into application in their own context. But to do so, it's widely recognized in the trainings that there is a political dimension. To be able to implement this technical approach, you need political supports, and you probably need some political movement and actions to get to put in place the approach. It's also presented as an approach that is very flexible. It's one of its advantages that it could be mobilized in different contexts by different people, as both Patsy and Nicole pointed out to. So the training really insists on this advantage of flexibility. It's also horizontal, so that different actors contributing to the HiAP approach needs to work on from the same level, talking to each other horizontally. It's also presented as an approach that is long-term, that the results will not come right away, but it's about collaboration slowly, but with very long-term and lasting impact. And finally, it's an approach that is presented as bringing coherence across governmental sectors. That's basically the main point of it. It's over and over in the trainings that by bringing different sectors together and different actors together, you break silos and you ensure that governmental sectors work together. So one sector does not undo what another sector is doing, that there is more logic and coherence between what they do. And the approach in the training is also presented as part of the solution for wicked problems. Wicked problems are very complex problems like poverty, climate change, systemic racism. So things are very complex to face with, but by bringing more people together, different governmental sectors, the approach is presented as a solution to this. The training often mentioned the idea of cost savings. So by being more coherent, by facing wicked problems, you can get economies on the long run, so cost savings for governmental sectors. Another important thing that is mentioned over and over in the training is this notion of win-win. So that for HiAP to work, you need not only benefits for the health or public health sectors, but really benefits for other sectors as well. So by working together, you get gains in terms of health, but also in terms of economic development, education, whatever other sectors participate. And that's presented as a fundamental element of HiAP, that you need to bring other sectors together and that they obtain benefits from their sector's perspective. So because of this cost-saving win-win long-term, it's presented as an approach that's advantageous for society as a whole. So not only for health and health equity, but in many different aspects of society that can benefit from the approach. We also found more specifically that the trainings tend to focus on the logic behind the approach and its principles. So most trainings try to explain what the approach is, what are the advantages of it, how it works, its basic principles. And in terms of competencies, they tend to focus on, for lack of a better word, soft competencies. So they insist a lot on things like communication, diplomacy, negotiations to bring the different sectors together. That's really the main focus in terms of competencies. And we also found in the trainings that tools presented tend to be more conceptual than practical. So a lot of the tools offered and discussed are about analyzing the situation, analyzing the context, try to understand what is going on. Things like stakeholder analysis, for example. So more than very concrete practical tools that have been put in place. So based on those findings, we include a few conclusions in the report. The first one is that there is a comprehensive learning content to integrate HiAP, fundamental principles and general understandings of the approach. In other words, the professionals wanting to learn about HiAP can find many excellent resources to learn about the approach, how it works, the logic behind it. That's very well covered in the trainings. However, we also found limited means to transform these learnings into applications. So it's not always clear in the training how those professionals understand the approach can actually go into the field and put that into applications. That's the challenge of it. And one of the reason trainings might lack some applicability is that HiAP is flexible, right? So it has to adapt to different contexts. So the learners or the participants are expected to learn about HiAP and adapt it to their own realities. So that's probably one of the explications why the means to put learnings into applications are sometimes lacking. We also found that trainings tend to talk mostly to health or public health actors, even if HiAP needs the implications of other sectors. And finally, we also found that we didn't find trainings that were adapted specifically to Canadian context. So on the reality of the Canadian Federation, different provinces, Indigenous realities, things like that, we didn't find trainings that offer information specifically for these contexts. So based on these different findings, we end the report with some suggestions of how to move forward. So some reflections. Of course, here, those are more general suggestions. They're not empirically based as the rest of the report, but it's more our contribution of what we think we could do to move forward. So we think that at this stage of HiAP development, trainings could be more applicable and concrete. It would be beneficial to offer tangible policies, examples, specific tools, trainings that support the implementation of HiAP in very specific context. And to do this, we propose or suggest the idea of creating workshops to adapt HiAP for specific actors, specific organization, context, different sectors, or specifically the Canadian reality. So to have very concrete workshops that bring the actors and try to help them apply HiAP directly in their own context. And of course, doing this is resource intensive, both financially and from a human resource perspective. So we also had some other suggestions. For example, to complete a needs assessment, to go on the ground, see what people need in terms of trainings and HiAP, what they want in different regions of Canada, different levels. Another solution could be to create a virtual course that would include modules aimed at different sectors and actors. So instead of having one big HiAP training, having a course that could respond to different needs, to different actors looking for something different. And finally, guidance by experts. So here we move away a little bit from training, but having resources, consultants, where people can talk to move forward and implement HiAP in their different jurisdictions. So that's a very quick overview of the report. Of course, you can read it if you're interested by the issue. Before we move to more the question and answer questions, I would like to pass the floor to Patsy again to ask her from a training perspective. So you mentioned the co-learning model. Can you tell us a bit about what you have done so far in terms of trainings and how you envision to move forward in sort of building capacity and training? You've mentioned it a few times, but I'm really curious to hear how you perceive it. So I'll stop sharing my screen.
Okay, well, I think a lot of it is coming from our experience. When we first started out, we're really thinking that we would be looking around for training programs, something like you have been reviewing, and we will look more deeply at what you have, no question. But what the other piece that we have discovered is that a lot of it is really contextual, as you've said. And so you can have the concepts. You can have a lot of initiative happening where there are different individuals who are recommending health and all policies, but until you get a group of people together who have some critical questions that get asked, and then you find some people to come the next time so that you can ask those questions and get some information, that it appears to me that we may be setting ourselves up here for something that could be the better way to go. So you're building relationships, you're building some of the, if the groups are such that they are ones that work either together or have an impact, they're community leaders or municipal leaders, or in our sense, they're a very intersectoral group, then as the questions unfold, the answers also come, the answers. So thinking of it in that way, we've already been building that capacity. So if you think, what is the purpose of training? It's about building capacity to do this work. There has to be knowledge, but there also has to be some understanding. And so I really think that's what's happening. We're also wanting to look more closely at having people start to document what they're doing and learning how to develop their own case studies, especially in some of our communities that are very small and rural communities that may have not a lot of resources or municipal staff to actually develop health and all policies as such, as we might imagine in a bigger organization. But it also has them looking at how they work with their communities. So there are resources in the community. It may unfold in a very different way, look quite different. Maybe that's the way to go. So that's where I'm looking at it as that maybe we're already into it. We keep thinking it's something in the future, but when I look back at that education session that you were at, I think that was kind of the beginnings of it, people asking the questions. Okay, so then let's just keep going in a circuitous way until we all get to a point where we reach out to other groups, and then you built this mass of capacity that's able to do the work. That's where I am.
Yeah, that's very interesting. So if I understand correctly, it's basically training comes from exchanges and using the knowledge and the competencies of all the different stakeholders involved, and then you learn from each other. So that's very interesting. So maybe I can ask Natalia, who will be transmitting some of the questions, if there are questions in the Q&A box. You're welcome again to ask your questions. We have another 10 minutes or so we can try to answer these questions.
Thank you, Martin, and hello, everyone. Yes, we do have questions. The first one is for Patty. So would you please, can you please let us know a bit more or talk about what mental health and health policies looks like? Do you advocate for specific policies or specific wording, language, or a particular approach or lens to be applied to all decision making?
Well, I'll answer it in this way. There's two parts to that. One is, I believe it's a lens that we bring to all decision making, but it also requires a rethink of what mental health is. And that's where understanding mental health as a resource, and that there's a difference, not to say that we should not be investing downstream in mental illness or more issues where there's stress that needs intervention or diagnosis that needs intervention, but really to be thinking about the majority of the population that most of the time are out there struggling with the day-to-day life and the challenges of day-to-day life that really need those good community supports around them and need policies that are going to address some of those conditions that cause the bigger stress in our lives or would really support protective factors. So for example, I'll give you one that I can think of is in urban planning, when we now know that there's a housing shortage in most places, and we're going to be building apartment buildings. But is it enough just to build structures, or are we going to start remembering that people are going to live in those structures and that people need places to socialize and build social supports and be outdoors in nature? We've got lots of research that tells us the importance of all these things, but when it comes to making those decisions, are we really considering them, or are we really just thinking about the immediate need if we've got to have housing? So it's really looking at, as I think you would find if we start looking more closely at mental health, we'll actually have better policies that impact all health, because there's no health without mental health, I don't believe. And so that's really the answer to the question. I hope I answered it where you want to, but I think we've got a lot of educating to do about mental health, period.
Thank you, Patsy. And just so you know, I copied the link to the brief, to the policy brief in the discussion. I have a question for Nicole. My long understanding is that Quebec's Department of Finance does not participate in health impact assessment as dictated by the Public Health Act, Section 54. So is this still the case? And if so, how have public health advocates dealt with the absence opposition of a key central agency?
Yes, thank you for the question. It's a good question because it's a fact. From the beginning of trying to implement Section 54 has been a concern by health authorities. That it is documented in the literature that it's been difficult to implement, especially with the sectors with an economic mission from the start until this day. So it is a documented fact. So you're right, the person who wrote this. Department of Finance, yes, but all departments with primarily economic mission are more or less interested in a health in all policies approach. But this is not specific to Quebec. In fact, like we're talking about health in all policies, but it is also documented that in most countries, health in all policies, in fact, consist in working with more adjacent sectors. So education, housing, and so on, in the implementation of HiAP. This is what happens on the ground. So the concept is wide, but the reality is a little different. But this is not to say that, this is why I was saying, what are the contributions? The outcomes of Section 54 are difficult to measure, like really did it create more health in Quebec society? It would be hard to measure and to answer, but this is why I was presenting some of the contributions is that it served as a stepping stone to develop the comprehensive HiAP approach program that we have today in 2016. So you're right in your observation, but this is all I wanted to know for now, to say for now. Thank you.
And I have a question that actually all of the panelists can maybe contribute to. you discuss initiatives and highlight context, but could you say something about Indigenous knowledge and teaching? Is it taken into account? Is it taken into consideration as a lens to, you know, design training programs and policies?
I can start if it's okay with you. In terms of training specifically, since that's part of my presentation, that's something that we highlight in the report, that the Indigenous lands, or even just as contributors, that's really absent from the training. We haven't found trainings that are either by Indigenous groups or talking to. So that's one thing. So it's not present yet. So as to move forward, I guess the next step would be a consultation to see if Indigenous communities and groups would be interested by the approach, because they only have a conception that is close to this more holistic view that we tend to have, that the Western tradition tend to have. So so that would be, I guess, the next step: re-consultation, see if they're interested, and if it could be if the Indigenous lands can be integrated to new training. That would be important, especially if they're interested in different Indigenous communities. So far, not so much. So it would be important to move forward in that direction.
Well,
Would you have anything to add, or wait, go ahead, Patsy.
Oh, just to say that I think we're really respectful of the holistic approach that Indigenous communities are taking, and also want to learn from them. I think we've had representation. We're working hard to build relationships with many of our representatives and communities, and have that input taken very seriously and considered. So it's learning, again, it's learning together. That's all I can say right now, is really building those relationships so that we can learn together and build that. And that is, we don't have a specific training program per se just now, but we are certainly in building the policy. We've done that, and in rolling out our initiatives and programs. We are.
So I think we're at almost 2:15. So I don't know if you wanted to add something, Natalia, before.
I have one quick question here. Let me see, because it's not in the Q&A. It's integrated knowledge translation. One of the knowledge mobilization approaches, strategies for implementing HiAP.
Natalia, can you repeat the question, please?
Yes, sure. Let me see, because I have to. Yeah, so the question is, would you say, based on, you know, everything you have just presented, that integrated knowledge translation, it's one, or could be one of the knowledge mobilization approaches or strategies to implementing health enough policies?
Patsy, do you want to take a go at this one?
I think it's all about knowledge mobilization, really. I mean, that's what we've been doing, and it's not just about the communication per se in messages. It's about actually meeting with people and having that opportunity for discussion and interaction, and the sharing of knowledge, getting the feedback, and taking our understanding and our knowledge a step further. They're just momentum, and I do feel that what we've been going through the last few years has been a knowledge mobilization process, to the point where it's more of a movement. You can see it moving over time. So that's really my response to it. I don't have anything that's documented it as much as what you might, either the other two presenters might have, but it's more the actual experience. We will be documenting our whole project and all our work, and it will be there for later. Right now, we're so in the midst of doing it that it's kind of hard to get anything more than just sharing the experience of it.
I think we're 16, and I don't see any more questions here.
Yeah, well, thank you very much, Natalia, for asking the question. So I'd like to thank everyone who was in the audience listening to us or watching us. Thank you very much, Patsy, for sharing your experience with us. That was very interesting. And thank you, Nicole, also. And I also like to thank the support teams from the NCCHPP, so Mylène, Alexandra, who are helping us technically. If you want to learn more about any of these elements we've talked about during the seminar, please visit our website. And I remind you that you will receive an email with an evaluation form. So if you have a few minutes, please give us your feedback. And you will also, the recording will also be available soon after. So thank you very much, everyone. Have a good day.